Hello and welcome to Team FRCR 2B Viva practice session for another CNS module. I'm again very thankful to the set of volunteers we have for tonight. These volunteers make these sessions possible. So without wasting any more time, I'm Sabahat and I'll be examined by Dr. Anil. So let's get started.
Okay.
Let me stop the chatting. Okay, yeah, go ahead. So this is seizures for a 15-year-old male. Yeah, I should have the control. Do you want me to go to number 2 or you'll do it?
Yeah, yes, number 2.
Okay. So I would like to start with T2, if that's okay.
Yes, any sequence you wish.
Okay. So this is a multi-sequential, multi-planar MRI images in a 15-year-old male with seizures. I'm looking at the T2 axial images. I'm going caudocranially. Okay. I'm taking a second look. I'd like to see the flare, if that's okay.
Yeah, okay.
So again, I'm going from the caudocranially. I'm looking at the brainstem, at the cerebellum. I'm trying to locate any abnormal signal intensity in the infra or the supratentorial location in a patient with history of seizures. Till now, from the flare and the T2, I have not been able to pinpoint any abnormality. The cortical cell sign gyri look fine. The basal ganglia, the thalamus, the internal capsule, at least on flare, looks okay. Would you tell me which sequence to take?
Yeah, I will advise you to take T1.
T1, okay. So now I'm in T1 and again, I'm going from vertex to down. So on T1, the cell sign, the gyri, I'm looking at the subarachnoid spaces. I'm looking at the white matter. Okay, this is a patient with seizure, a young child. I would be very closely looking for any gray matter heterotopia, which can also be a cause of seizures in a pediatric child. I have come again to the infratentorial location. I'll go back again because you have advised T1, so it should be present here. This is the basal ganglia, the thalami. I'm going up. The gray matter. Apologies, I still cannot find the abnormality.
I will give you a clue. Wait.
Yeah.
Okay. Can you see here?
I can see that this is the thalamus.
Okay.
This is the basal ganglia.
Okay.
The caudate.
Okay.
This area looks a bit fuzzy if I press too much.
Okay. So only you are looking at the periventricular region for heterotopia.
Yes.
Okay. Anything else means anywhere apart from the ependymal
Yes.
region?
Yes, we should be looking at the white matter should be here throughout.
Okay.
I think this area might be the heterotopia of the gray matter. If I'm not mistaken, that is the only thing which I can look for.
Somewhere anterior.
Anterior.
Frontal lobes.
Yes, this is in the deep white matter. This is the gray matter.
Okay.
Maybe here as well.
Okay.
This is the gray matter. Okay,
Yeah,
this is the
okay.
linear band of the gray matter. I think because we see the gray, then the white, and then the gray. So this is the gray matter heterotopia here.
Okay. Okay. You have the control.
Okay, so this is a 70-year-old male with fall. Oh my God, sorry, I forgot to turn on the timer. Uh, it's already 5 minutes. I think I should put it at 9 minutes maybe. Okay,
Okay, okay.
So this is fall, unequal pupils, unconscious 70-year-old patient.
Okay, you have the control.
Yes, I'm pressing the CT now.
Okay. You can
So,
take any sequence,
okay,
any
so
plane.
I'll start with the axial,
Okay.
non-contrast CT brain.
Okay.
I'm going from the caudocranially. I can clearly see that there is a hypodensity in the left parieto-occipital region with loss of gray-white matter differentiation. Um, there is no mass effect. I'm going superiorly, coming back to see if I am missing any other area of hypodensity in the cerebral hemisphere. But I think this is the area of hypodensity which I can see.
Okay.
If I can take the coronal to further. Yes, so this seems to be an area of hypodensity involving the left parieto-occipital region. Um, I think this is the area of my main differential here would be infarct ischemic insult, because the patient is unconscious, he has unequal pupils, because this is the area of optic radiation, optic pathway as well.
Okay.
So my prime differential would be a left ECA infarct. I would I can further investigate it with an MRI, and if required, a CT angiography. But next step, I think, would be a MRI brain.
Okay. So MRI is busy. The patients are occupied with the MRI. So
Mhm.
MRI is not available now. So what will you
Okay.
do?
I'll do a contrast enhanced to see if there is any thrombus in the circle of
Okay.
Willis.
Okay. Can you see any
Uh,
thrombus in this in your provided images?
no, actually, no. There, I cannot see the. Usually, we see the hyperdense MCA. I'm not, but in the posterior, I do not see any. Okay,
Okay.
look, I'm
Stop it.
tracing the basilar. As I
Okay.
go
Stop
up,
here.
I can see this basilar tip becomes very hyperdense. So yes,
Okay.
this is a basilar tip thrombus,
Okay.
which would explain the left posterior circulation infarct involving the left cerebral hemisphere, the occipital region.
Okay. Okay. Yeah. 1 second. Yeah, they have done the perfusion study and this the finding.
Okay, I am totally unexperienced in it, but I'll have a go.
It's okay. It's
I
okay. No issue.
believe
No issue. Yeah.
I believe that the abnormal area is being showed by this reddish area in the map.
Yes. Right.
Um, but I think this shows that there is still this is beyond the what you call it, uh, like this cannot be salvaged now, because it has gone in the red area. But honestly speaking, I'm not much aware of
Okay.
this
Yeah.
the
This the
maxillary.
perfusion is showing reduced perfusion of the involved area. So this is a
Okay,
thromb. Edema has already occurred. So you would like to get the history, and if this is the patient is in the window period, then we will go for the thrombolysis, and post thrombolysis you can take a CT for further evaluation. Okay, we will go to next case.
okay. So this is a 20-year-old female with temporal lobe epilepsy. I have pressed the CT. I think they're loading the
Yeah,
images.
12. Okay, 9. Okay, any sequence you
Okay,
want, any section.
okay. I'll start with the axial,
Okay,
um, and I'll go up first. So I'm going from vertex to downwards. This is axial, CT brain, non-contrast,
okay,
which demonstrates a hypodense area involving
okay, okay,
the right temporal lobe.
okay,
Um, there is a rim of maybe a calcific focus at the periphery.
okay,
The Lesion seems predominantly cystic. At least
Okay.
on this non-contrast, I cannot see any solid element within it. It is in
Okay.
close approximation with the, in close vicinity to the vessels as well. Now, in a
Okay.
female patient with temporal lobe epilepsy, um, this could be sequelae to previous surgery. This could be like surgery for removal of lesion. This could
Okay.
be an epidermoid cyst. This could be an
Okay.
area of arachnoid cyst, or a
Okay.
temporal lobe tumor,
Okay.
which is in this region.
Okay.
Um, I would take this case further with an contrast enhanced MRI.
Hmm.
And of course, if there are any previous imaging available, I would look at them as well.
Okay. Is it intraxial or extraxial?
Um, okay. I think when I look at it seems to be in very close approximation with the cisterns here. I'm trying to look that whether the uh, brain parenchyma is being pushed either medially or laterally. I think it
Okay.
is. So I think this is extraaxial. I would
Okay.
classify it as an
Yeah.
extraaxial.
Okay. Another investigation is done. You can go ahead with that.
Okay.
You can choose any sequence.
Okay. So I'll start with an axial T2. So the axial T2 and the region of interest, that is the right temporal lobe, shows a high intensity lesion in the right temporal region. I'll go to the FLAIR, and I can see that it is suppressed, but not completely suppressed. Going to the diffusion weighted images, it has high signal intensity. I'll match it with the ADC to see if there is a low corresponding area. Relatively low, not
Okay.
as low as I would like though.
Okay.
But okay, let me see other images. Okay, and there is one contrast. Okay, with these images possible at high DWI and relatively low ADC, I will keep it as an epidermoid cyst in the right temporal region. This patient would need referral for management to neurosurgery.
Okay.
Okay, this is a 20-year-old male who has 10 months of right arm weakness.
Okay.
Okay, I have pressed number 2. So this is an MRI. This is a 20-year-old male who has 10-month history of right arm weakness. I have been provided with T2, um, cervical spine in neutral and flexion position. So I'm first looking at the sagittal T2 in the neutral position. I'm trying to look at the cord. There is no abnormal signal within the cord. I'm trying to look for any um, intradural lesion. Um, the spine looks fine, although it's a bit odd for a 20-year-old. Okay, now I can see that in the flexion, the cord is being pushed forwards. Um, there seems to be something in the extramedullary
Okay.
region which is pushing it anteriorly. If I remember correctly, the entity is called the Hirayama disease.
Okay.
Um, and the patient would need referral to neurosurgery for further management.
Okay. Okay. Anything else you want to
I
ask
would
in
like
the
to do,
history?
sorry, I would also like to do a contrast enhanced MRI to see if
Okay.
there is any underlying lesion or
Okay.
fistula which would be
Okay.
present and is being missed on a T2.
Okay. Okay.
Uh,
How
we
much
have
time?
we have 15 seconds left, so I think we can stop here. I
Okay.
started
Okay.
the.
Yeah. Anything want to else? Anything more you want to see in this case?
Uh, I think I would look at the whole spine maybe to see if
Okay.
there are
Okay.
any other lesions.
Okay. And yeah, this is the Hirama disease only. And purposefully T2 axial is not given because to you need to see the images in the sagittal only and with the dynamic fluxions. So you rightly picked up. There is thinned out cortex in cord, cervical cord at the level of C5, C6 level. So on flexion, there is increase in the vascular space. The vascular channels and the extra posterior dural vascular channels will increase and cause the anterior compression. So this is the case of Hirayama. So regarding the previous one,
Mm-hmm.
yeah, previous one is the arachnoid cyst. No, sorry, epidermoid cyst involving the temporal lobe. Yeah, your DDs were right, and you should be explaining. Yeah, as you told, it's extraxial lesion, not an intraaxial, not an infarct. And
Yes,
you told post-operative complication also, but there are no signs of operation in this image.
true.
So the
Yes,
bones are very much intact. She has not
yes,
undergone any surgery. Okay, yeah, this is the case of right children fissure, epidermoid cyst. Okay.
yes. Okay,
Yeah, regarding the second one, 1 second.
no problem.
Yeah, your second case was, yeah, this one. This is the acute case. This is an emergency case.
Yes,
Posterior circulation stroke.
yes,
Yeah, as you saw, the thrombus in the basilar artery. Usually, in an elderly male with sudden loss of consciousness, you should suspect posterior circulation stroke.
right.
And yeah, in the case, you saw the tip of the basilar artery. As it has started from this image only, the tip of the basilar artery is very dense when compared to
Yes,
with the other arteries. So, and you
yes,
can see the density. You can see the difference in the density of the cortex, cerebral parenchyma with the right and left. So this is
yes,
a case of stroke, and you should follow all the stroke protocol and alert the stroke team for
yes.
further management. And the first case, yeah, it's the yeah, you were right in seeing all the sequences, and it was a quite difficult case, I think. Uh, and your track was right. So you're looking for the seizures, source of origin of epileptic convolutive focus. So
True.
with this the in the T1 image only you can see the abnormality. Can you see the you can
Yes,
see the white matter means gray matter between the white matter. So
true.
this is a case of band heterotopia.
Right.
Okay, yeah, right.
Thank you so much,
Done.
Dr. Lee.
Yeah, you're done very well. Okay.
CNS, not my forte. I know I have not built up very well, but thank you for such great cases and for
Yeah,
such great
yeah, but
learning
your
points.
approach was right.
Thank you so much, Dr. Lee.
Okay,
Thank you.
okay, okay. Yeah,
If you could stop sharing, Dr.
yeah, I stopped.
Rashida. Yeah, thank you so much. Dr. Rashida, you are next. And Dr. Nuran, you will be the candidate.
Yeah. Do you hear
Hello?
me?
Yes, we can hear you loud and clear, Dr. Nuran.
Thank you. Good evening for everybody.
Good evening,
Hello,
dear.
can you hear me?
Yes, we can hear you. Off to you. Go, both of you. Go ahead.
Okay, fine. Can you see my screen?
Yes.
Okay. So, hi, Noran.
Hello. Hi.
Okay, so I'm ready when you are.
I am ready.
Okay, fine. So, do you want me to give you the control?
Yeah. How can I take the control from the view option as you told me before?
I'm also trying to find how to give you control.
Go to the view options,
Then yes.
and you can request control, request mouse control.
Okay. I think I did.
Okay, yes, I can see you now. So I've approved it.
Okay. Now you both should be good. I'm starting the timer now.
Do you have control, Noran?
Let me just check.
You'll have to click and move. Yeah.
Yes, you have control. So you can start.
Okay.
Okay. Let me. Well, you didn't give me any history about this patient.
Yeah, I did that on purpose.
Okay, thank you. So can I start first of all from T2? Maybe it will be more helpful.
Okay,
Yes?
that's fine.
Yeah. Well, this is selected images of T2 weighted MR sequences. I'm starting from above, from the vertex downward, and it's going quickly. Yes, I'm trying to look to the white matter and gray matter, but the mouse is going so quickly. Yes, there is a mild, I think this is an old age. How old is he or she, this patient? Can you tell me at least his age?
About 70.
70. 7-0. Okay, so there is some prominency in the lateral ventricle, maybe due to cerebral atrophy, senile atrophy. And I think that I am not moving the mouse so comfortably.
Okay, just try and be slower with it. You can use the arrows at the bottom to click so it doesn't move too fast for you.
Okay, in this way. Okay. So, okay, I'm just looking to the posterior fossa now, and I think extending down. Maybe I will go the reverse. I can take a little bit more information from these. I'm looking to the pontocerebellar angle, to the cerebellum, and then now temporal horns, temporal lobes, then extending more superiorly. Well, there is some tiny hyperintense lesions periventricularly and in the frontal white matter, both sides. Maybe these are small micro ischemic or lacunar infarct, which goes with this age of patient.
Okay.
Let me go to the flare.
Okay.
Yeah?
Okay. Continue.
Yes.
Continue.
Yeah. This is coronal flare. And yeah, there is prominency in the thigh, and because of cerebral atrophy, as I told, senile type maybe, the lateral ventricles also prominent. So many artifacts, motion artifact. Here, I think there is some asymmetry between both ventricles. So I should concentrate at least on this area maybe, or maybe it's positional.
Okay, you mentioned that the ventricles are prominent.
Yes.
So are they dilated, or is it obstructive, or it's non-obstructive?
Yes. First of all, I thought it is prominent due to cerebral atrophy, but I think it is more than prominent. It is dilated. Even the third ventricle looks really dilated. It is triangular in shape. So I need to look to the sagittal. Maybe there can find something obstructing the pathway of CSF.
Okay.
Yeah. So I don't see here anything. Maybe other sequences will help more. What do we have here? Okay, let me see the axial contrast enhanced images. Dilated ventricles in an old age. Maybe he has ataxia or
okay, so he presented with urinary incontinence.
Yes, incontinence. That's what I'm going to ask. Well, if there is hydronephrosis and ataxia and incontinence, I think this is Adam's encephalopathy, where they have hydrocephalus and incontinence.
Okay.
And yes.
Okay. So okay. Do you know the other name this is called?
Well, I'm trying to think quickly.
Okay.
Yes, now I'm so excited. I can't remember it.
Okay.
The old name is Adam, as I remember. Adam's ataxia.
Do you see anything causing the obstruction? Do you see anything causing obstruction for this? As in, is it an obstructive hydrocephalus or is non-obstructive?
Yeah, well, it's usually non-obstructive type. Is the whole hydrocephalus is dilated in these cases.
So how can you differentiate this from age-related changes? Because you thought it was age-related changes initially. So yeah. What do you see on imaging to tell you that this is not likely to be age-related?
There is no hyperintensity around these ventricles, and the sulci is not so prominent, and also because of the clinical picture of incontinence and ataxia, I think all these confirms the syndrome of Adam's ataxia. Yes.
So what would you do?
Well, I will, yes, I will talk with the referring clinician, and it's better to be discussed in the MDT with the urologist and with the neurologist, just to manage the patient correctly. Yeah. Can I go next?
I'm already clicking on the next case.
Lovely. Okay. Well, again, no history, I think.
Yes.
Thank you. You are so
Please,
friendly.
guys, sorry to interrupt. Do not write on the screen, please.
Okay.
Go ahead.
Yeah. Well, here is T2 weighted selected images of brain, MRI sequence of brain. I'm trying just to move. It's not moving. Yeah. Oh, it's difficult.
It's moving now. It's moving now. Try clicking again.
Okay. Sorry, I'm going so slowly.
No, it's okay. Yeah, it's moving. It's moving. Just keep pressing on the arrows. It was moving.
Well, these are T2 weighted images. I'm looking to the ventricles. There is no dilatation, and looking to the gray matter, basal ganglia, and reach the cervix, vertex. And now going back, just want to know if there is any abnormal signal intensity or space occupying lesion. The midline, there is no shift. I'm just talking just to gain time to see if there is anything possible. Now came to the orbits. I think there is some tortuous optic nerves. So there is here, yes. Well, here the optic nerves looks like tortuous, and there is increase in the subarachnoid space surrounding the optic nerves. Okay. And even the sella torsica looks more prominent here. And the cisterns is prominent. So I would go further with the sagittal one, maybe help me in this matter. Okay. There is increase or prominence in the CSF spaces, and as if it is going down there. Here it's very crowded area, and I would like to see the flare also, if there is any other. The patient, is he presented with headache, postural headache, or?
Patient presented with visual abnormalities.
Visual abnormality, okay. So, well, slit-like ventricles here, it is very narrowed, I think, here in this sequence when I go down. So I think this picture gives me the intracranial hypotension, idiopathic intracranial hypotension, because there is increase in the subarachnoid spaces and the narrowing in the ventricles and tortuosity in the optic nerves.
You mean? You mean hypo?
Yes.
Okay.
Yeah, hypo. Yes. Yes.
Okay. Okay, I'm listening.
Okay.
So what would you do?
I will talk with the referring doctor, and maybe there is a leak in the CSF. That's why it's causing the hypotension. So it's better just to talk to the referring neurologist or neurosurgeon and told him, and if necessary, we can take also spinal MRI just to see if there is any leak in the CSF that causes this hypotension.
Okay.
Thank you. Yeah, go next.
Yeah, I'm already going to the next case.
Okay. Well, no history as usual, so I will start with T1. We'll start with T1 weighted selected images, MRI sequences. I'm waiting just to load the images.
It's taking time to load. Sorry about that.
Yeah. While I'm starting from this session, from this section slide, there is a hypodense area which looks like vasogenic edema surrounding the occipital horn of the lateral ventricle. Let me go up or down. Just loading, so I need some time just to finish loading.
No, click. This particular series is completely loaded.
Okay. So there is loss of white gray matter here on the right side, and there is diffuse blurred parenchyma and some diffuse effacement of the sulci and the adjacent lateral ventricle. So I will look to the T2 weighted images just to gain time. Okay, I'm clicking T2, but yes, now. Yeah, as I expected, it is a vasogenic edema surrounding an area of hyperintensity. And when I look to vasogenic edema, so it means that something hidden behind this area of edema. Let me look to the FLAIR images. Yeah, there is hypointense, maybe mass lesion. And
no, this is not FLAIR. This is ADC.
Okay, sorry. Yeah, so in ADC there is
the contrast enhanced. Go to the contrast enhanced.
Yeah.
Yeah, T1 with contrast.
Okay, I'm just looking. Where is it?
Okay, don't worry. Let me click it for you.
Okay.
That's
yeah.
it.
Well, yes, there is a ring enhancement of this hypointense lesion, and which is surrounded with a vasogenic edema, and causing a. So in a ring enhancement, that means it is a cystic lesion with a ring enhancement. It could be cystic metastasis. It could be an abscess or septic emboli. So I would like to know the clinical picture of the patient if he has a primary tumor, like a breast. It could be breast metastasis, and or if
patient has had a previous cancer of the scalp.
Okay, so
that was operated.
Yeah, yeah. Sorry, there is a defect here in the cranium. So I think this is a encephalomalacic area due to previous operation, and there is a linear contrast enhancement around it. I can't see within this cystic lesion any residue or precipitation of a previous or recurrent tumor.
Okay, look at the diffusion sequences and tell me what you think.
Okay, diffusion. Where is diffusion?
DWI, yeah.
Okay, here.
And look at the ADC.
Yes, the diffusion is very restricted, and ADC is low.
So what do you think?
It looks like abscess. Okay. I think, yes, this is abscess. So maybe it is post-operatively contaminated and gained an abscess. So I would phone the referring neurosurgeon and will tell him about this, and just to start the management either by conservative treatment or if it needs any other possible management.
Okay.
Yeah.
Is that time up?
Okay, yes, I just let the case to be finished, so the time is up to you. Yeah.
Thank you, thank you.
So well done, Oran. Even though I didn't give you history, you were able to still compose.
Very tough examiner.
Well composed. So very well done. So yes, you've got this. This is a case of brain abscess, but there's actually more to it. There is also ventriculitis. So if you look at the contrast enhanced, you see that the ventricular lining is also enhancing. Can you appreciate this?
Yes.
Yeah. So there's some ventricular enhancement, and you didn't pick this defect initially. Yeah. So this patient has had previous surgery and now is complicated by a brain abscess with ventriculitis. So
what do you mean? The ventricular enhancement is important for abscess or previous?
Yeah, because you can see some focus of infection here. and it's
Mhm.
very closely related to the ventricles. We should also look out for any involvement of the ventricles in that case. So
Thank
we
you.
can look for ventricular epidermal enhancement. There may also be debris within the ventricle, which would also restrict on DWI. So there could be ventricular abscesses as well. So we
Okay.
can look for that in the contrast enhanced and the diffusion sequences.
Thank you.
Okay. And then the previous one, you actually called it intracranial hypotension, but it is actually intracranial hypertension. I also have I'm also trying to clear it in my head. So there are two different conditions actually. Why is it not loading? Okay. So this particular one is a case of intracranial hypertension. And the features on this case, um, just a minute, I'm trying to load it.
I'm just always
So like you
confusing.
said, you saw the slit-like ventricles, you saw the tortuosity of the optic nerve, the increased subarachnoid space and CSF space around the optic nerve. And you also saw a partial empty cellar. So these are actually features of the benign intracranial hypertension. Other features they can present with include acquired tonsillar herniation, but in this case, this patient did not have it. So there was no tonsillar herniation in this case.
Okay. Is it
So
due to leak
also
of
another
CS?
thing, sorry?
Is it due to CSF leak or what?
No, the hypotension is one that is due to CSF leak. This is not due to CSF leak. So in this case, once you suspect it, you want to also look at venous sinuses because they usually have stenosis of the venous sinus.
Okay,
And so you
thrombosis,
may want to do
stenosis, yeah.
a CT or an MRV to look for any narrowing of the dural venous sinuses. And if you find stenosis, then the management could involve stenting of the stenotic sinuses. They could also, if they're having visual symptoms, and you may want to do fenestration of the optic nerve to avoid loss of vision. And also lumboperitoneal shunts can be done. So this is how they are managed. So
Thank
we
you.
need to be able to differentiate them from hypotension. And in hypotension, what those ones usually present with is they have
Contrast enhancement, diffuse, thickening.
they have distension of the venous sinuses.
Yeah.
Like in this one, there is stenosis, but in hypotension, there's distension. And also in both of them could have tonsillar herniation. So that is common with both of them. And what are the features? And then in hypotension, they could also have subdural collections, like subdural hygroma.
Yeah, you are right. Thank you.
Those are
just
the things.
just confused.
Yeah, so it's very easy to mix it up. I also have that problem. God help me. So those are the ones that you want to look for a CSF leak. So you may want to look ask for any history of runny nose. Maybe they have the CSF otoria, and then you want to look for the site of leak. And to manage that, you now use the patches, epidural blood patches to block the site of leak. So we need to play with the differences. Yes.
Yeah, thank you.
So this was hypertension. So the first one was a case of normal pressure hydrocephalus. The name you call it is not a very common name, actually. I've also come across that name once, but I can't remember the full name myself. But it's commonly called normal pressure hydrocephalus. And the features are, like you mentioned, there's ventriculomegaly, but there is no obstruction. So it's a non-obstructive ventriculomegaly. And the reason why you know it's a normal pressure hydrocephalus is the floor of the third ventricle does not, bulge inferiorly. So that is why the sagittal is very key. So you can see that the floor of the ventricle is, sort of normal. It's not bulging inferiorly. So that tells you that it is of normal pressure. It's not like an obstructive one whereby there's significant distension. And then, and in this case also, you mentioned that there's no transependymal seepage. There's actually some transependymal seepage, and that is why they need to have a shunt in place, or else they will continue to deteriorate. So we need neurosurgical referral, because we can see this hyperintensity in the periventricular region that is suggesting that there is some transependymal seepage. So they need to be shunted.
Okay, thank you.
Thank you, Dr. Rashida and Nuran. I love Dr. Rashida's style. She
Yeah.
comes with the authentic to be examiner, no history, no expression. Very nice. I
In
love
these
her.
cases were very, they would give you the answer. So I didn't want to
True, true. No, no,
Yeah.
no. You were perfect.
No,
I really enjoyed the session. As Dr. John Curtis would say, great stuff, huh? And
yeah.
thank you.
I'm also grateful to you, Dr. Rashida. You
You're
are
welcome.
show me very great cases. I will never forget them
I'm glad.
again.
And I'm also
Oh,
learning from the cases myself. Thank you too.
thank you. Okay, next is Dr. Manu. If you would share your screen, and Dr. Abhijit, you are next.
Yeah.
Okay, the screen is yours.
Okay. Okay, I am provided with lateral cervical spine radiograph. I am looking at the bones. I am not able to find any abnormality in the bones. Now I'm looking at the airways. I think there is some thickening noted at the level of epiglottis uh, with probably the thumb sign. So I'll correlate with the history of patient. If there is acute respiratory distress, then my differential will include epiglottitis, or differential can be croup. So I'll correlate with the history of patient and convey my findings to the referring clinician and refer the patient to the pediatric team on an urgent basis. Your voice is very low actually, Dr. Manu.
We can't hear you, Dr. Manu.
Dr. Manu, I can't hear you. Hello, hello.
Yes, Dr. Manu, we can't hear you. No, it's very muffled. We can't hear you, Dr. Manu. Maybe change the mic, or maybe just speak directly in your laptop, maybe. It's coming from very far away, actually.
Yeah, very faint voice.
It's better, but still not clear.
Manu, you can click at the mic area and select your and change your microphone. At the right lower quadrant, you can see you can select the microphone and change it to your laptop system.
Faintly audible, but it's okay. Hello.
No, it's not okay.
Or what you can do is you can ask the questions in the chat like that.
Yeah.
It's not
Okay.
possible.
Okay.
Manu, you can ask the questions in the chat.
I'm opening the chat, but no one should discuss the case. It's only for Dr. Manu and Dr. Abhijit. Go ahead.
This is the next case.
No, it's not the next case, I think. Is it?
I think this is the next.
Okay.
Okay. I've been provided with lateral radiograph of cervical spine. I'm looking at the bone of the patient, and there's this mild straightening of the cervical lordosis is noted. No significant degenerative changes seen in the cervical vertebral bodies. I'm looking at the soft tissue, prevertebral soft tissue. I think there is a mild thickening of the cervical soft tissue noted at the C2 to C4 level, actually. So rest of the part appears unremarkable. Visualized skull appears normal. So As per these findings, my differential include prevertebral soft tissue thickening, that is might be because of abscess or some infective pathology. So I'll correlate with the history of patient and advise CT neck for further evaluation. Okay. Okay, I'm provided with sagittal. Can I get the control?
Yes, you have the control. You have the control.
Okay, I have the control, but I'm not able to, okay. I'm not able to scroll.
Yes, now you can scroll, right?
Yes, yes.
Okay. You are doing great, Dr. Abhijit. This is innovation. Go ahead.
Okay. uh,
Don't click on the image, click on the sides, and then use
okay,
the
okay.
mouse scrolling or the arrow buttons.
Okay. I'm being provided with sagittal images of the cervical spine. I want to see the bone window setting of the sagittal images. Now I'm looking at the bones. I'm not able to see any lytic or sclerotic foci in the visualized vertebral bodies. So,
The
and
patient has a history of road traffic accident.
okay, okay, okay. Now I'm looking at the bones, no evidence of any obvious fracture I can see in the visualized vertebral bodies. Uh, I want to see the axial sections.
Okay, you can have.
I'm looking at the bones. No obvious fracture is there, but I think there is a mild thickening in the prevertebral space
Yes.
with widening of the prevertebral space. So in terms of the history of the RTA, it might be pharyngeal or prevertebral hematoma that might have caused its widening. So no, however, I am not able to find any fracture in the visualized bones. So
You can have a
so
look at the SAG bone window once again
okay, okay, okay,
and look for anything is other factors. The sagittal section.
okay. Now I'm looking at the sagittal images again to find out any fracture or the loss of alignment.
Leave apart the factors.
Okay, okay. The alignment are normal. Hmm.
You can have a look
So
at the base of skull.
okay, okay. I'm looking at the base of skull. The clivus appears normal. Occipital bone appears normal. Okay, clivus, I think is fracture or not. I'm not able to appreciate the any abnormality in the base of skull except with prevertebral hematoma in
Go to
this
the
patient.
MRI. I will go to the MRI.
Okay, okay, okay. I'm provided with the sagittal T1 contrast fat sat images. I can see this abnormal signal intensity involving the cervicovertebral junction, including the upper cervical cord. The correlating with the history, it might be because of the cord contusion and involving the cervicovertebral junction. So, keeping with these findings, there is a cord contusion in the patient, and I want to look at the prevertebral space to confirm my finding of the prevertebral hematoma, prevertebral space hematoma. I think there is a prevertebral space hematoma also. So rest of the cord appears normal, no signal intensity change in the visualized vertebral bodies. So this is a cord injury, cord contusion with prevertebral hematoma. So I'll urgently convey my findings to the referring clinician, and it needs urgent evaluation by neurosurgical team. And in the meanwhile, I'll give the support to the patient by airway or by cervical collar if needed.
The patient, the GCS was still very poor and he had a activity head.
Okay, the same patient. Okay, I'm provided with axial sections of CT brain images. I can see there is a multiple hyperdense foci at the gray-white matter junction in the bilateral cerebral hemisphere. This might be the diffuse axonal injury in the history of road traffic accident. Rest of the brain parenchyma appears normal, no evidence of any extraaxial bleed, uh, extraaxial bleed noted. Rest of the brain parenchyma appears normal. So diffuse axonal injury is my diagnosis in this CT images. So this is also a surgical or is an emergency. I'll urgently convey my findings to the referring clinician and need urgent neurosurgical referral. You are not audible. Sorry, Dr. Manu. Okay, okay. There's tentorium along the tentorium and the falx, the hyperdensity is noted. So might be because of subarachnoid hemorrhage or subdural hemorrhage along the falx and the bilateral tentorium. Parenchyma, there is a diffuse hypodensity with loss of gyral sulcal differentiation. So might be because of diffuse cerebral edema is there. So that might cause of loss of differentiation of gyrus and sulci. Same patient. Okay, I want to look at the DWI images. Now I am looking at the DWI images. Okay, there's a multiple hyperintense linear hyperintensity is noted in the bilateral sulcal spaces of bilateral frontal along the right basal ganglia also. So this could be the subarachnoid hemorrhage, and I want to see the GRE images or SWI images to confirm my findings. Multiple foci of blooming is seen along the right basal ganglia, bilateral cerebral hemisphere, predominantly in the bilateral frontal region. So this is the diffuse axonal injury with subarachnoid hemorrhage along the tentorium and along the falx. So I'll convey my findings to the referring clinician and refer the patient to the neurosurgical team. So I'm provided with a patient of 4-month age female with microcephaly. I've been provided with axial T2 weighted images of MRI brain. I can see there's mild atrophy with prominence of subarachnoid spaces on the bilateral side with agenesis of corpus callosum and septum pellucidum. So I want to confirm that on the sagittal images. So I can see there is a genesis of corpus callosum with bilateral parenchymal cerebral atrophy is there. No significant altered signal intensity seen in the rest of the visualized brain parenchyma. No gray matter or heterotopia or any other abnormality, parenchymal abnormality noted. So bilateral ventricle is also along the parallel orientation is noted with prominence of occipital horn. So my diagnosis would be the corpus callosal agenesis. So I'll convey my findings to the referring clinician and refer the patient to the pediatric neurosurgical team for further evaluation and management.
I think Dr. Manu and Dr. Abhijit will make this the final case. Dr.
Okay.
Manu, if you can go full blast and we'll make our volumes maximum and see if we can hear you. No, at least I can't. Abhijit, can you hear him?
No.
Okay, what we can do, if rest of you would agree, Dr. Manu, you can type the diagnosis maybe or points in the chat box, and we can proceed to the next session. Can you try again, Dr. Manu? Can you talk again? No, very muffled. It's okay. I think you can just use the chat box while we go to the next. I'll keep the chat box open. But thank you so much, Dr. Manu and Dr. Abhijit. I think you did great in the sense because these technical issues can happen in the actual exams as well.
Yes,
and you kept yourself composed and kept on, minding the business for which you were here, kept talking. So very well done. And I think I remember that Dr. Amdad was asked that how many cases is ideal, and he said nothing is ideal. People are shown 7 cases and don't make it, and people are shown 2 cases that they pass. So I think your cases were the ones where there was whole trauma of the neuro there. So Dr. Manu, we would be really grateful if you would just put it in the chat box. I'm keeping the chat box open. Guys, do not discuss the hot seat cases. Dr. Manu would be just putting in his diagnosis and the points. We would move to the next session. Thank you, Dr. Manu and Dr. Abhijit. It's Dr. Kamal who would be examining Dr. Sanij.
Hello.
Yes, hello, Dr. Kamal.
Okay. You people can listen me?
Yes, we can.
Okay. So
Dr. Kamal is in a full mode today.
okay, let me give him the control. Can you
Kamal,
please ask me, Sanij?
Yeah, we are seeing the folder only, Kamal. We are not seeing the video.
Okay.
That movie is not seen.
Okay, 1 minute, please. Okay now? Can you see?
Yes.
Yeah, I can see.
Okay, start. I have give you the control.
Okay, so I have to click here, right?
Yeah. No, not here, sorry. Can you click here?
Here,
No.
okay.
The keyboard,
Okay.
the keyboard press.
Okay, keyboard. Okay. Now it's working. Yeah.
Okay. Young child
So,
altered consciousness.
So this is a MRI brain T1 weighted image of a child with altered consciousness. So it's axial section. I can see there is T1 hyperintensity, periventricular T1 hyperintensity around the left lateral ventricle, the posterior part of the lateral ventricle, and also there is a diffuse T1 hypointensity with the loss of cortical and subcortical differentiation, gray white matter differentiation at the anterior part of frontal lobes and also involving the basal ganglia. Okay, so there is a diffuse T1 hypointensity involving the right parietal region also. So there, I'm not seeing the ventricles clearly. That may be due to compression at the anterior part. I'm not seeing the ventricles clearly. So I would like to see the T2 weighted image if available, and the flare or diffusion.
Okay, so this is T2.
So yeah, this is T2 weighted image. One second. I have to click the down arrow or the right arrow?
You can click directly over here and yeah.
Okay. So this is a T2 weighted image where I can see the abnormal areas which are shown in T1 weighted images are hyperintense. They are diffusely hyperintense and some areas of isointensity in between. And there is but I can see a rim of cortex around the lesion in frontal region and also in the parietal region. So I would like to see other sequences like diffusion weighted images if available, or flare.
So this is diffusion.
Diffusion.
Yeah. Go directly beyond this.
Beyond this.
Okay. Yeah.
There are areas of diffusion hyperintensity, multiple areas of hyperintensity seen in the involved areas. So can I see the ADC?
Yes, the hyperintense signal areas are showing low signal on ADC.
Okay, so this is a diffuse, in summary, it's a diffuse abnormality involving the entire cerebral hemisphere. Majority of the cerebral hemisphere spheres bilaterally, sparing the temporal lobes. And there are areas of acute infarct with some gliotic changes involving the cerebral hemispheres. So I'm thinking the possibility of
Keep going, keep going.
I'm thinking the possibility of a acute ischemic insult like hydranum cephalus, like any occlusion of vessels.
So here you can see the ventricles as well.
Yeah.
I think so.
Yeah, I would like to see the angiogram if available.
Sorry, no angiogram available.
So I'm thinking the possibility of an acute vascular insult causing this infarct and maybe ischemic necrosis or coagulative necrosis is my differential. So I would like to ask for any hypoxia or any.
Okay, so now you have this post-contrast images.
Okay, sorry. So I have been given a post-contrast image where I can see there is a peripheral enhancement of the areas, involved areas, suggestive of any inflammation. So this could be multiple brain abscesses are a possibility with the infection. So I will compare with the clinical history of the patient and will inform this as a referring clinician regarding this. Most probably it's an infective etiology with the peripheral enhancement of the involved areas.
Okay, so we will move to the next case.
Yeah.
Let me stop the share and I will open the next case.
Okay, thank you.
Okay. So this here again, unconscious patient presented in emergency department.
Okay, so this is a MRI brain of a child, unconscious, presented in the emergency department. Sorry. Okay.
Sorry.
No worries.
Okay, here you go. Adult patient presented unconsciousness in emergency department.
So this is an adult patient presented unconscious in the emergency department. It's a T2 weighted axial image. Sorry.
Okay.
T2 weighted axial image. I am seeing from below upwards, where I can see abnormality involving the left temporal lobe with the T2 hyperintensity, with involving the white matter, and there is also T2 hypointensity at the cortex with some intraaxial lesion probably. There is some involvement of the right thalamus and basal caudate nucleus with. Sorry, are you moving or me moving?
It's me moving.
Okay. So so I would like to see other sequences like T1 or diffusion weighted images, or so this is the flare in images where I can see the involved areas are again T2 hyperintense, and that is bilateral involvement at the basal ganglia, right thalamus, and left frontal and parietal regions. So in a patient coming with unconsciousness, there is involvement of the brainstem also. Can I see the diffusion weighted images? So this is a T1 weighted image. So this is diffusion weighted
diffusion.
image. There are T2. There is diffusion hyperintensity, and this is ADC.
This is diffusion.
This is diffusion. Okay. There is cortical T2 diffusion hyperintensity at the involved areas, and there is some hyperintensity involving the corpus callosum also, the posterior part of corpus callosum, and also at the centrum semioval at the white matter on the right side, multiple patchy areas. So can I see the ADC and the SWA if available?
Yes, you have this.
So this is a SWA images where the T2 hypointense areas are blooming. So they are the areas of hemorrhage, I think. This could be like a patient coming with a collapse. It can be a hemorrhagic. It can be a intraaxial hemorrhage causing these symptoms, but it's not a typical occasion of hypertensive hemorrhage. But this. One second.
So I want you to look at the T2 again, and any cause you can make out.
I am looking at the flowoids, the vessel flowoids at the vessels. I am looking for any aneurysms and any
aneurysms with two different place hemorrhage. You are looking for aneurysm?
No. Sorry. So I'm looking at it's a non-arterial territory. Like I'm looking at other causes.
Okay, so I provide you the T1.
Okay.
Anything you can make out?
Yeah, I can see some hyperintensity involving the. Let me see. I'm looking at the veins. I can see some hyperintensity at the internal cerebral vein area.
Okay.
And some cord-like hyperintensity at the internal cerebral vein area. And I'm also looking at the other dural sinuses. Yeah, there is some hyperintensity at the transverse sinus also on the left side.
So
this
any
can,
reason you can make out for this thrombosis on the given images?
so the reason for the thrombosis, I am looking at the mastoid air cells. I am looking at the sagittal, at the paranasal sinuses. I am looking at the temporal bone for any causes, but I couldn't see. So this is venous influx, hemorrhagic transformation of venous influx. But I will see the MR venogram.
So there
to
is
look at
thrombosis.
Yeah, there is thrombosis, extensive thrombosis at the right, the leftist transverse sinus. So I'll discuss with the ER team, and this patient needs a referral to neurology and the stroke team for further management.
Okay. We move to the next case. Patient has a known case of lymphoma. Can you ask me the control if you want to?
Yeah, this is a known case of lymphoma. I have been given CT scan.
Now presented with altered sensorium. Okay, you can move.
CT brain, I can see some, 1 second, soft tissue opacity involving the left maxillary sinus. And this is a plain CT plain image.
Go on the next video, just stay on this.
Okay. 1 second. So again, I'm reviewing the images once again, where there is some disproportion in the size of ventricle, and I can also see there is at CT there is hypodensity involving the right temporal lobe. There is white matter hypodensity, and and there is soft tissue opacification of the left maxillary sinus. That's what I am seeing here. So with the given history, the patient is having...
Can you please tell me more about the hypodensity you were talking about in the temporal lobe?
Yeah, that is predominantly involving the white matter, but there is some involvement of the cortex in some areas. But I can also see some relative hyperdensity at the cortex, and there is no loss of gray white matter differentiation in those areas. It can be vasogenic edema, but I would like to see. I'm not seeing any obvious mass, but there is some difference in size of ventricle that may be due to mass effect. I'm looking for any other lesions. This patient needs further evaluation with the MRI to look for any cause for this edema. And so this is a T2 weighted image where the involved areas are T2 hyperintense. There is cortical swelling, like diffuse cortical swelling at the involved areas with subcortical white matter T2 hyperintensity. And I would like to, there is, it's predominantly, but there is some involvement of the opposite side also. Just can I see the other images like flare or diffusion?
What additional thing diffusion will give you in this case?
Maybe I would like to see the diffusion abnormality or any.
Are you thinking of some restriction or infarctions like things on this?
Or I will see any contrast images if available.
Okay.
So this is a flare image and it's a T2.
And I'm providing you the contrasts.
Okay. So this is a contrast, T1 contrast images.
You can scroll it yourself.
Okay. There is I've been given the T1 contrast images. I'm looking. One second. There are. I'm looking for any abnormal meningeal or leptomeningeal or any intraaxial contrast enhancement or any enhancing mass.
Patient was a known case of lymphoma.
Okay. So I'm not seeing any. I'm seeing some subtle cortical enhancement here in the temporal lobe. So I would like to correlate to the history, like if there is any radiation or if there is any
Not
treatment
provided.
treatment given.
Not provided.
Or then this could be.
Yeah, it's fine. It's fine. I think so.
Okay.
We are done.
Yes,
Okay.
you can
Yes, time is
now
over.
give the feedback. Yeah.
Okay. In this case, you were right that there is a vasogenic edema. Actually, it is not involving the cortex, and gray white matter differentiation is well maintained. But I think so. On the zoom or in the screen, it's not much evident, but there are multiple tiny punctate foci of enhancement are over here in this region. If, asymmetric as compared to the contralateral side, as well as where the edema is there on the T2, so there is also a little bit there. So this was a case of secondary CNS lymphoma.
What?
CNS lymphoma, there were the tiny lymphomatic deposits over there.
Okay.
The other case, you were right later on that there is a thrombosis, but it is due to there was moderate fluid in the bilateral mastoids. And the patient has a long history of the CSOM and ear discharge, which leads to the thrombosis of the veins and leading to these hemorrhages in the brain.
Okay.
And in the first case I shared was the multiple cerebral abscesses.
Sorry, Dr. Kamal, you can share
Yeah.
the case. It would be better.
Okay.
The first case.
The first case I showed was, I think so. Let me open the case. Give me the minute.
Sure, take your time.
Can you see the video?
We can see the whole set of videos. You still have to start one. We can see the screen. Yeah. Now it's gone.
Yeah, I'm sharing. Okay.
Yes.
So this was the case. So this was the case of multiple cerebral abscesses with liquefaction of the white matter. These were the abscesses. These four in the frontoparietal and the parieto-temporal lobes, parieto-occipital lobes, and this is the liquefaction, proteinaceous material within them. The one of the abscess on the left side is also showing T1 hyperintensities. And on the post contrast images, there was intense enhancement of these, as well as the enhancement of the ventricular lining. The patient was a known case of meningitis with leading to these multiple cerebral abscesses, liquefaction of the white matter, and the ventriculitis. Okay.
Okay, Dr. Kamal, thank you so much.
This was the case which was shown to me in the FRCR preparatory course in Dubai, which I
the
attended of
course.
the Dr. Nadeem.
Okay.
Yeah, the same case was shown to me by some Indian examiner. I don't know who was he, but I can't remember the name. But the similar case he showed me, and he was asking me that what sequence you want to see. I think so in routine practice, just I'm taking 2 minutes, but I want to add the point. They don't show the each and every sequence, but once you see one or two sequence, they always ask what sequence you want to see.
True.
And then you have to tell that I want to see post contrast or diffusion. According to that, what is more important, you have to ask for that. So that's
True.
why I asked you, Dr. Sunil, that why are you asking for diffusion and not for the post contrast images in that case? So this happens to me in the FRCR to be Viva preparatory course. So this was the point I want to share. Okay.
Thank you, Dr. Kamal.
Thank you,
Great
Kamal. Thank you.
cases.
Thank
And
you.
thank you, Dr. Sanij, because you adapted suddenly to a different set of scrolling. Thank you so much.
He performed very well. He performed very well.
Yes, yes. Okay.
Yeah.
While you unshare and Dr. Sanij shares,
Yeah.
I just, because this would go to the video upload in the YouTube, so I would just share the diagnosis of Dr. Manu's case because we couldn't hear him clearly for a record. So Dr. Manu showed the case 1 was acute epiglottitis. Case 2 was atlanto-occipital dissociation, diffuse axonal injury, spinal cord compression, and hematoma. And third case was semilobar holoprosencephaly. Okay, so now we can move to our next set. Dr. Sanij would be vivaing Dr. Awad. Both of you, the screen is yours.
Hello?
Yes,
Yeah,
Dr. Awad, we can hear you.
Dr. Awad, these are
Yes.
very simple cases. I have taken very simple cases. Okay, I think I'll be means
Nice example.
my cases will finish soon because these are very simple. Okay.
Okay.
So
Okay. Can I start?
No, I'll start. No worries. Okay. I'll give you the remote control. You can ask me the remote control.
What's the remote control? Okay.
Okay. You can scroll.
Not working. And, I am using.
You can click and scroll. You can. Oh, sorry. You are moving to the next. Sorry.
Yes, no problem. You can scroll, no problem. I am scrolling with the laptop, but not working. Yeah.
Okay, I'll scroll. So you can ask me where to stop.
Okay, this is a multiplanar multi-sequences MRI of an adult male patient, 30 years, I think.
You can tell me what. You can tell me where to stop.
Yes, we'll stop at mid-sagittal. This is the sagittal T1. There is a focal cystic dilatation of the upper cervical cord of focal syrinx dilatation of low signal intensity in T1. There is also downward tonsillar ectopia or herniation. I want to confirm this. The corpus callosum is seen well developed, no associated hydrocephalic chains. Can we change to the axial T2?
Okay, you can tell me where to stop.
So here axial confirmed tonsillar ectopia and no supratentorial hydrocephalic, normal ventricular system. There is white retention, maxillary sinus cyst. So the constellation of finding of focal syrinx with tonsillar ectopia, I am suspecting Chiari-1 malformation. So I will confirm my finding to the neurosurgeon for possibility of decompression craniotomy if this is symptomatic. And also before that, I will recommend the contrast enhanced MRI to exclude underlying mass.
Okay.
Differential diagnosis would include Chiari-2 malformation, but there is no associated supratentorial signs of Chiari and no hydrocephalus. Also, other association with Chiari-1 is the fusion of the cervical vertebrae, but not here, and platypesia or basilar invagination. I can't see this finding.
Okay. So you told that there is some cerebral or tonsillar herniation. So what is the normal level? What is the
It is
normal level?
in adult, I think not beyond the 7 millimeter below the basion.
Okay. So I'll go to the next. This is also very simple. Okay.
Increased head circumference in 2 years old male.
You can ask me where to stop.
Okay, no problem. So this is a multilateral axial and sagittal T2 and coronal T1. I can see there is a posterior fossa, large posterior fossa cystic abnormality connected to the fourth ventricle. There is also absent aplasia of the pharynx, which is rotated superiorly, and there is
you can ask me to stop somewhere if you want.
Yes, here this is the enlarged posterior fossa by CSF cystic space connected to the fourth ventricle here, and I can see the. Can I see the sagittal T2?
Okay.
In the sagittal T2 also confirm the large retrocerebellar cystic lesion connected to the fourth ventricle with supratentorial hydrocephalic chains. There is absence of flow void signal in the aqueduct of Sylvius. This could be aqueductal stenosis association. So this is a case of posterior fossa cerebral malformation, classic case of dandy worker malformation with supratentorial hydrocephalus and aqueductal stenosis. I will confirm this finding to the pediatric neurosurgeon for the shunting.
Okay. So what is this?
This the trochlea.
Okay. Okay. We'll go to the next. So
this is okay. This transcranial ultrasound of probably a unit. I can see in the provided non-scrollable, non-shiny image. There is a echogenic mass lesion seen. Can I scroll? Can I see other image?
Which image you need? Coronal?
Coronal one. The coronal one, see that this is a mass lesion measuring 1.5 to 1 centimeter, seen at the region of the supratentorial and supracellular, I mean. This is the both lateral ventricle. Yes.
What is this?
This the ventricle, both lateral ventricle. So this is echogenic mass. If this is a neonate with a preterm, but I think this is a mass, not sign of germinal matrix hemorrhage. This could be just a mass lesion with the echogenicity, could be a lipomatous mass or lipoma. I will confirm this also by looking at the coronal and sagittal to see how the developed the corpus callosum. This power Doppler, yes, this is in the coronal image, seeing the mass with the poorly developed corpus callosum. So this could be corpus callosum dysgenesis with a pericallosal lipoma. I will confirm such finding with an MRI.
Okay. One second.
Okay. Okay. So this is a multiplanar MRI in sagittal reformatted T1, confirm fat signal intensity mass lesion in the pericallosal region with the poorly developed posterior part of the corpus callosum. This, I think there is two types, I don't remember. So this is a corpus callosum dysgenesis with pericallosal lipoma. You will confirm also in the coronal scene. Yes, the widely separated frontal horn of both lateral ventricle with a hyperintense mass seen also in, can I confirm also in axial? I see there is axial T2 fat sat.
Okay.
There is a homogeneous suppression of the mass in axial fat sat. So this is
So
common association of, in summary, this is a common association of corpus callosum dysgenesis with pericallosal lipoma.
okay. So you told that it is T1 hyperintense. So do you know what are the other lesions which will appear hyperintense in T1?
It could be the other lesion which are hyperintense in T1, hemorrhage and proteinaceous material and some type of calcification, rare type, I think, and also melanin and melanin, for example.
Okay. Okay. So do you know what are the types of intracranial lipomas available? The two types. Hello.
Curvilinear. Yes.
Okay.
Can you hear me?
Yeah, I can hear you.
Curvilinear and tubulonodular, I think.
Okay. What type is this? What type is this?
This tubulonodular type.
Okay. So we'll go to the next.
Global developmental delay and macrocephaly in 2 years old male.
Okay.
Okay. I'm presented with a multiplanar multi-sequences MRI of 2 years old who presented with macrocephaly and global developmental delay. I can see there are bilateral, more or less symmetrical, abnormal, subcortical white matter abnormalities seen diffusely involving the frontal, parietal, and occipital region. Also, I can see there is involvement of the subcortical uviber. There is associated atrophic change with the ventriculomegaly and the prominent cortical sulci. So, giving the history of global developmental delay, I am thinking of leukodystrophy type, giving also the distribution and the macrocephaly. It is not only confined to the frontal, so I'm excluding Alexander. Other possibility with macrocephaly could be Canavan syndrome. I see that I am provided also with spectroscopy. So this could differentiate between the causes. Okay. In spectroscopy, there is N-acetyl aspartate peak. So this is an extensive white matter disease with the leukodystrophy and associated quite specific N-aspartate peak, which is quite specific for Canavan disease. So I will confirm my finding to the pediatrician, neurologist for further management.
Okay.
We have 18 seconds, up to you guys.
So this is the last case.
Sure.
Okay. Routine follow-up referred from another country. Okay, this is a multiplan multi-sequence MRI of an adult patient who presented for routine follow-up. Can I see, this is in sagittal T1. Can I see the axial T2 and flare? Can I start by axial? Okay. In axial T2 weighted image, there are subependymal nodular abnormal signal intensity lesion that are iso-intense to the gray matter in T2 weighted image. Also, I want to check it is a signal pattern in the T1. So it is almost parallel in signal pattern to the gray matter in T1 and T2 weighted image. What else sequence I can see in the flare? Okay, almost in all signal, it is equal to the gray matter. So there are bilateral symmetrical subependymal nodular signal abnormality, most likely with subependymal heterotopia. My differential diagnosis would include subependymal cortical tuber of tuberous sclerosis, but this could be sometimes calcified and not with this. And I will confirm my finding and recommend if the patient.
So what will be the signal intensity in tuberous sclerosis, the subependymal nodules of tuberous sclerosis? Is it like this?
No, according whether if there is calcification, could be signal void.
Okay. So you are diagnosing heterotopia?
Yes, subependymal heterotopia.
Okay. So what is the other type of heterotopia?
Band heterotopia and other cortical dysplasia.
Okay. So you did well. So there is no need to discuss. I think all the findings you told. These are I told it. These are very simple cases. So I gave you
straightforward case.
Thank you.
Good start.
So I thought we'll have a difference, like maybe give some simple cases. So all the cases are you picked up all the findings. So this is the subcortical heterotopia, but you have to check for other abnormalities. When you see a migrational anomaly, you have to check for other migration anomalies. You have to tell that I'm checking for other anomalies like polymicrogyria or schizencephalia, whatever maybe.
Yes.
So you have to check for, if you see one microgyria, then you have to check for the other microgyria and associated features. So this one you did well. Maybe you have seen the MRS there always, but your approach was correct. Like it's a case with the macrocephaly. You told that you are considering Alexander disease, but that will be mostly involved in the frontal white matter. And you told that you are considering the Canavan disease because of the involvement of subcortical U fibers. And usually the occiput lobes are more involved, but also the frontal and parietal lobes can be involved, but there is some hyperenunciated thalamus also. And you correctly told that you will look at the spectroscopy, and that will reveal an increased N-acetyl aspartate peak, and that is very specific for Canavan's disease. And you will refer this to the pediatrician and pediatric neurologist, that you told correctly. And the other cases are very simple, like this one. This is a mid-sagittal image where you can see a well-defined hyperechoic lesion, and that's also between the frontal horns at the expected location of this is the corpus callosum, where we have to see the corpus callosum. And you are looking at the ACA to see whether there is any azygous ACA, and this confirms in the MRI examination. So when the cases are very straightforward and simple, then they may ask you some other questions like what are the T1 hyperintensity lesions. You told it correctly, like the lipid melanin lesion with high protein content, minerals like magnesium, and also the hemorrhage like early subacute and late subacute hemorrhage. So whenever you see a lipoma, intracranial lipoma, you have to check for, especially this location, you have to check for associated abnormalities, and there are the signs of corpus callosal dysgenesis like Viking helmet sign, then parallel shaped lateral ventricle, and other other associated features of corpus callosal dysgenesis. And they may also ask you the types of lipoma. You correctly told there are bulky tubulonodular and curvilinear type, and this is usually the bulky tubulonodular is associated with corpus callosal dysgenesis. This is a good case. This is a good pickup and description, but it's a very simple case. Usually this will be the sometimes the first case or something. They won't usually they will show some difficult cases. It's also you are fine describe all the fine when you were shown a on mini case, they are checking you to see say all the findings. So there was elevation of the upward displacement of the torcular hairophily. That was what I was asking you, and there was agenesis of the cerebellar vermis and dilatation of the fourth ventricle. That is filling the entire posterior fossa with communication with the lateral ventricle. So this was very simple, like Dandy-Walker malformation. You will, and this one also. You told that you will do a contrast examination to rule out a mass. That is correct. And you should also complete the spine imaging, like cervical spine and other spine. You just have to do the spinal MRI also. Otherwise, this is also fine. Very good. Congrats.
Thank you. Thank you.
Thank you so much, Dr. Saneej and Dr. Awad. Great session. Okay, now we are coming to our last session. Dr. Sulafa, if you can unmute yourself, and I will. Can you see my screen?
Yes, I can.
Okay. So I know you told me that you cannot scroll, so I'll have to scroll for you. Is that okay?
Yes.
Okay. So I'm starting the timer now. Go ahead.
50 years old with sudden onset of disturbed consciousness, which progressed to coma of 2 days duration.
Okay. I'll start scrolling just a minute.
Okay, so this is a plain CT of the brain. I can see that there are patches of hyperdense lesions on the, it's mainly hypodensity on the right cerebellum with mass effect. And midline shift. I cannot see the right lateral ventricle clearly. Also, there is hyperdense fossae in the extraaxial region and the basal cistern. I'm suspecting that there is brainstem lesion, also mass lesion. So also I am not sure if I saw there is hyperdense lesions on the left side in the most in the if you start from up.
Okay.
There is a hyperdense lesion.
Okay.
So
if you have to put it in one pathology, what will you put it? What are you thinking? Think out loud.
It can be a mass lesion with metastasis.
Or otherwise, what is the other possibility? Which is the
infective, like granulomatous disease, but
no history of infection.
The thing that the hypodensity on the left side can be an infarction, but
you mean the right side?
The right side, sorry, but the only thing is this extraaxial hyperdense lesions.
Okay, let me tell you, this is not extraaxial. It is within the brainstem. Now connect all these things.
So within the brainstem.
Can you tell me more about this hypodensity? By hypodensity, what do you mean? What is the etiology of the hypodensity in this patient who is in coma?
So this mainly brain edema.
Because of what?
The
first thing you'll think when we are doing our routine work every day, if we see such a large hypodensity involving the right cerebral hemisphere,
Yeah, so I think it's this hypodensity is mainly because of there is herniation.
Good. Why is there herniation?
Because of the mass lesion in the brain stem.
Okay. Mass lesion is a good differential. Let me cut it down. This is not a mass lesion.
Infarction. This is an infarction, acute infarction.
Okay. So what sort of herniation is there? Can you explain?
I don't recall the name.
No problem.
You can describe. The problem that I don't have any coronal or sagittal reconstruction.
Yes, there isn't. I'm being the mean FRCR to be examiner who just wants you to diagnose everything on this axial. I don't have anything else for you.
Ankle herniation.
Good.
I think, and with the secondary or infarction.
Okay, this infarction is where? Which territory?
Mainly MCA and BCA also. There is some, mainly MCA.
Okay, we'll come back to it. Well done. Okay. Your next case.
20 years old male with altered conscience, VB shunt.
Okay. You're doing great, Dr. Sulafa. Go ahead.
So this is non-contrast CT of the brain. There is, I can see the VB shunt. It's deep in the left lateral ventricle.
Right.
So this is a young patient. I'm looking for the cause of why he was shunted. If you can scroll
anything else you would like to see when there is a shunt? Something else you'd like to see? I'm not asking you to look for the cause. What else would you like to see? The clinician knows the cause, but he wants you to evaluate something else.
Yeah, I would like to see is this shunt working or not. There is hydrocephalus.
Excellent.
I'm seeing it as prominent temporal horns mainly.
Good.
So
which means?
It means that the shunt is not functioning well.
Excellent. What's your next step?
I will first compare with the previous one.
It was okay. The previous one was good. It was decompressed.
So I don't see any transepidermal spillage at this
okay, I agree.
level. I will immediately inform the neurosurgeon about my finding.
The neurosurgeon wants you to do something next. Other than
MRI?
the MRI. No, he doesn't want MRI.
Contrast?
No, he doesn't want contrast. I'm sorry, I'm being mean, but this way we'll remember, right?
I know.
So the VP shunt is not working, right?
I will ask him to examine the patient.
No, you know the clinicians. He wants you to do all the work.
I want to see the other coronal and cervical.
It's the same of the brain. What else will you do apart from CT brain? Okay, let me give you something else. Just tell me, what is this? What is this series called?
Yeah, I will do VB shunt series. I will check if there is any kinking, any interruption along the course of the VB shunt.
Okay, so this is the skull. Describe it.
Okay.
This is the neck.
At the neck level, I don't see the shunt clearly. I don't see the.
Till where do you see the shunt? Till where do you see the shunt?
I see it up to the mandibular angle.
Excellent. Now the chest. Describe it.
I still cannot see the shunt.
Excellent. Now the abdomen.
So now I can see the shunt looped in the abdomen, and it is disconnected. Disconnected. It means that there is discontinuity.
So the discontinuity was at which level?
At the level of the mandible.
Excellent.
Mandible
okay.
angle.
Good. Next, we are going to the next case. Okay.
Okay.
So I'm being
Adult
Dr.
male.
Rashida today. No history.
Okay, adult male.
I'm
So
scrolling.
this is a non-contrast CT of the brain. I can see a rather well-defined hyperdensity in the supracellular region. I would like to examine it in other, in coronal and sagittal if possible,
so,
or if we have contrast
I'll
enhanced.
give you contrast later. What are you thinking? This is a lesion in the.
So my differential is first thrombosed aneurysm. It's hyperdense in this location. This is my main
is it
differential.
only supracellular or you call it cellular?
Cellular and supracellular.
Okay, so you said thrombosed aneurysm. What is the other one? Sorry, I missed. What is the other differential you said?
No, I did not say anything.
Okay.
Okay, my others could be craniopharyngioma if the patient is young.
Okay.
Meningioma,
okay,
and it is also hyperdense. There is a long list of differential, but
okay. Will you recall again? Will you tell me again the location?
Cellular.
Okay. So what else can become in the cellar?
Yeah, it can. We can have the I forgot the name.
Okay, no worries, no worries.
The microadenoma and macroadenoma.
Okay, so a pituitary lesion, right? Okay, I'm giving you the arterial. Can you rule out something on this arterial?
I can rule out the aneurysm.
Okay, so what are you thinking, and what do you want to do next? What are the differentials you are left with?
So first is it's not microadenoma, it could be a macroadenoma. And this is my so now I'm more thinking that it's a cellular lesion with bulging roof. So I'm left with the macroadenoma, craniopharyngioma, not typical, no cystic component, no calcifications.
What do you want to do next?
I will do MRI.
Okay. So these are static images, okay?
Okay.
Just let me know what else do you want to see. Yeah.
So in T1, it is hyper intense, coronal, okay, in the post contrast.
Describe the lesion and the relations.
Okay. So it's the relation, the gland itself, it is compressed down.
Excellent. Yes.
So I'm ruling out the macroadenoma.
Okay. So what are you left
with? Is the enhancement is peripheral. I'm thinking of ractic cleft cyst.
Okay. So we are going to the next case. Okay. This would be our last case. Okay.
So no history.
No history. See, you'll remember this. So this is
okay.
T2.
This is a T2 weighted images.
Let me give you.
This is flare. So I'm seeing multiple lesions, mainly extraaxial lesions in the both TB angles and surrounding the brainstem. They are hyperintense in T2 and flare. Some of them are showing like popcorn appearance. Can I see it in the coronal?
Okay, I'll give you a choice of choosing something else if you want to. Do you want something else?
Other than the one available?
No. Other than the coronal T1. Would you like something else after seeing this flare?
Yeah. I want gradient.
No, I don't have gradient. I don't have gradient. Anything else? You see lesions in the posterior fossa on the axial.
Yeah, and the cerebral. Yeah, now I suspect
I'm
that
giving
some
you
of them are
T1
cerebral.
to save. I'm giving you contrast, okay, to save the time. So what do you see in the T1 contrast?
So in the T1, I see that these regions are intensely enhancing. Some of them are showing, oh, it's diffuse.
Yes.
Extraaxial and lining the like CSF spaces. So I have my differentials is first granulomatous disease, second diffuse meningeal mets.
Okay, let me tell you, it's not granulomatous disease, it's not meningeal mets. If you would see these lesions in the posterior fossa, what would you be thinking of?
Yeah, I would think about hemangioblastomas.
Okay, what will you do next? Multiple hemangioblastomas. What will you do next?
Yeah, so I would think about von Hippel-Lindau. I will do screening, ultrasound of the abdomen.
No, before the ultrasound, the patient is in MRI.
Yeah, I will do MRI spine, extend
Excellent.
to the whole
so
spine.
we'll rush through this case, huh? So what do you see on the spine? Just the main findings.
So yeah, it's there is the small lesions lining the whole spine,
which are
drop meta. It's called drop mets and it has another name. I don't remember.
So these are spinal hemangioblastomas. Okay.
Yes. Okay.
So this is ultrasound of the kidneys. What do you see?
I am seeing focal lesions in the
kidneys.
Kidneys.
So what is this?
This is a cyst.
And what is this?
This is angiomyolipoma.
Okay, I'll give you directly the portovenous phase. VHL, remember, this is not tuberous sclerosis, this is VHL. Now, give me the findings in the kidneys.
Okay, multiple soft tissue lesions with heterogeneous enhancement.
Excellent.
This can represent RCCs.
Yes, okay.
And
anything else in any other organ?
The adrenals.
Okay, I'll show you the adrenals.
And pancreas.
Yes, so tell me what is in the pancreas. Very good.
Pancreas, I have multiple cysts.
Excellent. So what is this? What is the syndrome?
Von Hippel-Lindau.
Excellent, Dr. Sulafa. Very well done. I know I hurried you up because I wanted to finish the case, but you did very well. So
I did not revise for a long time.
No, you did very well. So as you said, these were multiple hemangioblastomas, very extensive, yes. And in fact, there were some supratentorial locations as well. But this was a patient of hemangioblastoma. Next, you said spine. We'll do spine, and I'll go directly to this. And you can see all those enhancing hemangioblastoma. And here in the CT abdomen, you correctly picked up the pancreatic cysts. So in the VHL, you have in the kidney cysts, and also there are high risk of RCCs. So these were the RCC combination of the RCCs and the renal cysts. So very well done. This was VHL. Next, I put this case intentionally because I missed this case in my last Viva with Dr. Afsar. So this is, you correctly picked up, this is the Rathke's cleft cyst. The pituitary gland has been pushed downwards, and the optic chiasm has been stretched upwards, okay? And this is T1 hyperintense. The location is typical. This is Rathke's cleft cyst. The VP shunt, you did well. I know that when you see the hydrocephalus, you want to look for the cause of it. That is why I guided you that what the next we are going to do is to do the VP shunt series. And here you clearly clarity picked up that this was broken. So this was broken at the neck, and it was all coiled up in the abdomen. Now this one, I know this was a tough one. What is happening here, that this is a large infarction involving the right cerebral hemisphere. You correctly said that this is a midline shift, and this is actually the subfalcine herniation, okay? The word you were looking for was the subfalcine herniation. And this hyperdensity is actually the hemorrhage, which happens when there is subfalcine herniation and the ACA is stretched, okay? The anterior cerebral artery. So this was the hemorrhage due to the due to the pull or the push or whatever you want to call it, due to the effect on the ACA. And this is brainstem hemorrhage when there is uncal herniation. These are the Dura hemorrhages, okay? DURT hemorrhages. So this all can be put up in one pathology, that large infarction in the right cerebral hemisphere with subfelt sign and uncal herniation. The ACA is injured, so there is hemorrhage in the left side, and there is Dura hemorrhage because of the uncal herniation and the stretching. Okay, so thank you so much, Dr. Sudafa. Thank you very much, everyone. If anyone wants to add something, I'll